So I have been doing radio frequency for a long period of time, close to 30 years ago. And it's a great tool. The most frustrating thing for me was when you would do a facet injection, the patient would get 100% pain relief. Then you would do a medial branch block, the patient would get 100% pain relief. And then you do a radio frequency, and they didn't get a good result. And that's very frustrating for me as a practitioner, but obviously more so for the patient. I wanted to see what can we do to improve the outcomes to make it more successful. And one of the things that we looked at with the flare needle was two things. One, to make a larger lesion size so that you could have a better chance of capturing that nerve in the ablation field, and two, for comfort. The way that the port is actually just dispenses the local anesthetic onto the lesioning site. Most of the needles, when you inject through the needle, the port or the opening is at the distal end of the needle, and your lesion is just proximal to that. So you're injecting local anesthetic past where you're doing the lesioning. So it makes more sense to put the local anesthetic where the temperature is going to be higher. And so that port on the radiofrequency needle, the flare needle, the local anesthetic comes directly onto the active part of the tip where the lesioning is occurring. So it's a larger lesion because you're doing a bipolar lesion. It's a larger lesion. So your chances of getting that nerve in the active lesion zone is much higher. So one of the advantages on the flare needle is there's an injection port. So once you place your radiofrequency probe in, you can do your sensory testing, you can do your motor testing, and without having to move the needle, take it in and out, you can just inject the local anesthetic through the port so that you're not having movement of the needle. Flare, putting out the local anesthetic, not at the distal end of the tissue, and so using the smallest amount of local anesthetic that you can will reduce the pushing away of the tissue away from the needle or the active tip. And the other advantage is that when you inject that medication through the port, the local anesthetic comes out onto the active tip, so that you're anesthetizing the area that you're lesioning, so it's more comfortable for the patient. One of the other features is that probe is a bipolar needle. So the probe has the needle, the flare needle, has an exit port at the active tip. And so as you place the radiofrequency probe in, it comes out that side port and enables you to do a bipolar lesion, which is a much bigger lesion. So and 21 gauge needle will actually create a lesion size more equal to a 16 to 18 gauge needle. The patients are much more comfortable. I use much less local anesthetic. Basically, I've kind of fine-tuned it where 1 cc or 1.1 cc is about exactly perfect amount of local anesthetic that you need for that lesion, with the patient being comfortable without anesthetizing the nerve root and getting a weak extremity from the procedure. The flare needle, the length of the needle has to be used with a EpiMed probe. If you use some of the other probes, it's too short, so it won't come out the side port and give you a bipolar lesion. So it is really designed with that EpiMed probe in mind. It's designed for that exact length of the EpiMed probe. We have an assortment of different probes. They have stainless steel probes. They have not one-use disposable probes, and they use a nitinol. I prefer the nitinol. It's very durable. We have used those probes for hundreds and hundreds of sterilization cycles, and they have good data on the durability of those leads. So just changing from our regular needles that we use from radiofrequency to the flare needle, the results have been anecdotally much better. Patient satisfaction is better. I'm not bringing patients back. So overall, it's made a big difference in my practice.